Welcome back to blackdoctor.org, where wellness and culture connect. I am Dr. Cordai Decoto, board certified podiatrist, fellow of the Academy of Foot and Ankle Surgery, and podiatrist for Neighborhood Health. We're providing care for all, regardless of immigration status and or insurance. I am also the co-founder of Sisters in Podiatry, a Facebook focus group for Black women in podiatry within the United States and the Caribbean, and your host for Stepping Forward with Dr. D, a gateway to all things of the lower extremity. So grab your favorite beverage as we get ready to spill the tea. My first guest is Dr. Kia Grundy. Dr. Kia Grundy is a board certified pediatrician and a fellow of the American Academy of Pediatrics. She received her undergraduate degree from Hampton University, the real HU, I know, for all our HBCU friends, in Virginia, and received her medical degree from the University of Medicine and Dentistry in Newark, Jersey. She completed her pediatric residency and chief residency at UMDNJ, University Hospital in Newark, New Jersey. She spent this next several years in private practice prior to starting her own fabulous practice, now located in Maplewood. She also serves as a school physician for several charter schools in Newark, Irvington, Jersey City, Trenton, and Camden. You are all New Jersey, my love. She has been chosen as New Jersey's favorite doc since 2011 and has been a guest speaker for several schools and conferences. She enjoys focusing on obesity and lifestyle changes for children, asthma management, and attention deficit disorder. She focuses on tools to help her patients make positive choices, from their friends to their diet. She also has a special interest in providing care for newborns and their first-time parents. She has been awarded several honors over the years for her pediatric service in her community, but her greatest joy is her lovely family and is active in her church, Bethel AME in Vauxhall, New Jersey. And she is a dedicated wife and mother to two fabulous children. Welcome, Dr. Grundy.
Thank you.
Our next guest is Dr. Jarrett D. Kane. Hi, Dr. Kane.
Hello.
Dr. Jarrett Kane is an associate professor of orthopedic surgery at the University of Pittsburgh School of Medicine. He completed his doctorate at the Podiatric Medicine in Temple at the University School of Podiatric Medicine in Philadelphia. He completed his postgraduate studies in clinical epidemiology at the University of Pennsylvania School of Medicine in Philly, and a master's, because he's smart, in clinical research at Drexel University School of Medicine. Prior to his appointment in Pittsburgh, Dr. Kane was an associate professor at Penn State College of Medicine in Hershey, which I love that place for chocolate, Pennsylvania. Yes. He holds a dual certification by the American Board of Foot and Ankle Surgery in foot surgery and reconstructive rear foot and ankle surgery. His interests include disorders of the foot and ankle, the diabetic bone healing, flat foot deformity, and osteoarthritis. He has received various grants and presented research in various conferences nationally and internationally. We welcome Dr. Kane.
Thank you. Here.
And our last guest, my friend as well, Dr. Stephen Bowie, who is a surgeon, inventor, and has guided thousands of people to live a healthier, more active life. He is known as Dr. Active as he lives and breathes sports medicine and has been practicing sports medicine for the last 25 years with his special interest in posture biomechanics and injury prevention. He is, besides the podiatrist, he is a pharmacist and recovery expert. And in his spare time, he's a runner. So he's run 13 marathons. I don't run from anything but what I got to run from. And he's attempting to do an ultra marathon, which I'm going to ask you about, because I'm like, there's more than that. Good God, help you. He founded Active Life in 2015, which is a company that creates and promotes the world's best recovery and fitness products. His products are created and validated by a team of sports medicine physicians and physical therapists, and rigorously tested by a team in consultation with personal trainers and athletes. We love Dr. Bowie. Welcome.
Thank you.
So I love when people ask me when I do this show, how do I get my people? I said sometimes it's connections as friends. Dr. Boo and I were classmates. Dr. Grundy is my friend. I'm part of Femmes Noir Medical, a group of women of color in all fields of medicine in Northern Jersey. Dr. Kane was recommended by Dr. Lowell Scott Lowell Weil Jr., pardon me. And he was one of his fellows. So when he recommended you, it was not even we didn't even have to talk. I was like, if you like him, I love him. So I have all these fabulous doctors on the show. So Flatfeet, Flatfeet. Lord knows people always like, I got a flat foot. I'm telling you, I know. And we look at it sometimes and we're like, okay. Sometimes it's not that, and sometimes it's like you beyond the flat foot. Okay, I don't know. We're gonna tell you what that is, but that's beyond what you think it is. So I'm gonna start off with Dr. Grundy. So Dr. Grundy, I know when you get your pediatric patients, I know the parents are coming at you. What are the age that usually parents start complaining, saying, "Oh my gosh, Dr. Grundy, look at their foot, look at their foot, it's flat."
Newborns.
Really?
Oh my God, yes, yes. They are
Mm.
inspecting those babies. So newborns, I think they spend more they focus more on it when they're about 6 months on up, because now they're standing the babies on their feet. And they're just trying to figure out what's going on. So 6 months for sure, a year, definitely. And at that point I'm just trying to talk them down.
And we always, when we're asking these questions, we love to know where you're coming from. Let us know. We're hailing from, most of us, from Jersey, Pittsburgh, other Waynesboro. Did I say that right? Waynesboro, Pennsylvania, or Jersey, Stephen?
Waynesboro,
Yes.
Pennsylvania.
So we're here. We want to know where you guys are hailing from. I always love giving the shout outs. I see Gerard Snell. Good evening. Thank you for joining us. So, Dr. Grundy, what about your older patients? Now you have children that are doing sports. You know, a lot of, I think forgive me, I suck at sports. So I know we're in football season.
Right.
And I
So
know,
we're football going into basketball
there we
season.
go.
We are the great football players now because they've made it to the end of the season.
Hmm.
And it's, except for today, it's 82 degrees outside, but otherwise it would be the cold and frosty season. And then we're going into basketball. So I find when the kids are doing more running, the kids who are really doing competitive sports. So for me, I feel like that's more like middle school on up.
Hmm.
When they would begin to complain about it, enough that the parents would pay attention to it and bring it to my attention. And those are the kids who are super athletic and doing a little bit of this and that: track, soccer, basketball, football. Yeah, all of those sports.
So now I'm going to switch to our flip on our podiatry arm. So Dr. Bowie and Dr. Kane. So I know you see peds, but we also see adults. Dr. Kane, folks will complain and talk about they got a flat foot. I had no arch. My mama told me, and you're like, oh Lord. Tell us what, in layman's terms, what is an adult particularly, what is a flat foot? Because I love when people come in diagnosing themselves, the WebMDers, as I like to say. And they'll be like,
Yeah.
look, I'm telling you, and this and this and this. Tell us, what does that look like?
Well, I tell them in the most basic sense that, yeah, you have basically what they'll say is like you have fallen arches, and I'll agree. Yeah, it's when you stand and your arch collapses, or when you don't have a. Some people have an arch and it collapses, or some people don't have an arch when they're standing or sitting, and that's typically the signs of a flat foot. And yes, they'll say, oh well, it hurts with shoes and things like that, and so that's when you start kind of get into the kind of the basics of it. But what starts the conversation is the appearance. That's the conversation right there. So once they see the appearance, you start from there, and then you build on that and kind of guide them through what they have and how it interacts with their activities and work life schedule.
I agree. I say, yep, you're falling arches, and they're like, I haven't had an arch, or I had an arch when I was 16, and look at it now. Dr. Bowie, Stephen. So when adults, when we go back to children in a minute, but when adults come to you, what are the reasons that someone will come to you besides the appearance, as we talked about? What are some of the reasons or the symptoms that you see adult patients coming about to you about a flat foot?
Yeah, for me, we get a lot of patients that coming in. Their first complaint is pain in the arch. And they said, oh, yeah, I noticed my foot is really flat. And usually my first question to them is, as you mentioned before, and then as Dr. Grundy mentioned, is if your feet has been flat since the beginning when you were young, or is this something recent? Because if your feet are flat and they are not misaligned, that's a big diagnosis for us, is that if it causes symptoms and it causes misalignment, then it can potentially cause problem. But I treat a lot of professional athletes, including Kenyans runners, Olympic runners, and many of them, large percentage of them, has flat feet and without having problems. So there's not necessarily something is wrong unless there is a misalignment or symptomatic. And this is where we drill into it a little bit more. And obviously, if they don't have any symptom or doesn't have any misalignment, a lot of that would be education and giving them peace that, hey, it's okay if it does not need to be treated if your feet has been flat like this for a long time.
And I'm going to go back to Dr. Grundy. You talked about the Kenyan runners, and a lot of times, Kenyan runners have run barefoot or in what are those sneakers again with that you can slide your feet in with the toes.
Vibram, five finger.
Exactly. And then we have Americans who are overweight and ran in 12 years and decide to put them on and figure that they're going to be a Kenyan and run and end up in ER. And I'm like, who are you? Okay. Well, I saw on TV that these were I'm like, Kenyan, don't try this at home. Okay. It should be like something that says, I'm a Kenyan, do not try this at home, because we get foolishness in the ER with the fractures because somebody decided to live their best life one weekend and run, right? So
that's a very good point.
Very good point. Dr. Grundy, you were going to say something and I had a question for you as well, but go ahead.
So really not, it's more of a, because what I see is that it seems that I get more complaints when kids are wearing certain styles of shoes, right?
What type of shoes are you seeing?
The Vans, the Converses, the Crocs, even when they're doing,
Crocs.
and the Crocs, the Crocs.
I'm going to tell everybody, ugh.
okay. Yeah. But they, I have other shoes that I put on, but these kids live in their Crocs.
They do.
And it just seems to me that there's certain shoes that aggravate the situation more, primarily because they're trying to do a lot in them. And y'all can tell me because this is what you do. But for me, I'm typically telling them, get something with some sort of an arch support or something in it, because these really flat shoes aren't really helping the picture. Am I wrong?
Well, if I may,
go ahead, Dr. King, take it.
Question: the thing about adolescents and with shoe gear, they tend to go to what's the style and what's most appealing to the eye, not what's functionally best for them. And when you get into, I start talking shoes to the kids, and I start saying, hey, you may want to consider Asics, New Balance, or Cloud.
Dr. Kane, you're a hater on style. I know this. You got the teenage.
Hey, listen, yeah.
This old man, okay?
Clouds and Hokas are in. Clouds and Hokas are in.
Hokas, right?
And
he said ASIC and New Balance. I'm like, they're looking at him like, who is this old dude talking?
And the reason I say that is those shoes accommodate for different mechanics of feet, different width, different length, and they tend to have posts that accommodate for flat feet, which gets into addresses some of the biomechanical issues. Nikes don't. The Tatum 3s don't. The Sabrina Ionescu's don't. They look good, but they don't. They don't accommodate for that. So you're paying a lot of money.
Oh God.
So you're paying a lot of money, but your feet still hurt, and then you keep coming back saying why your feet hurt.
Making us
and the flip-flops, black flip-flops.
Oh God, and the flip-flops. People live in flip-flops, as you know, in the summer. I admit, I got cute shoes, but I do like a good flip-flop. But we have people who live in them, and then they come in and complain that their arch hurts or their Achilles hurts, and we're like, I just blink and say, yes, it does. So with that question, Dr. Grundy, going back to peds for a second. So you're seeing, we recap. We said, as early as newborns, when you start holding the baby and bouncing cutie patootie and you're like, his foot is flat or her foot is flat. When they start to walk, which is the age, Dr. Grundy, tell us tell us milestones for walking.
So early walker, roughly around 10 months. That's a really early walker. Typically between 10 and 12, they're pretty good. And we get worried if they're not walking by 16 months. So 16 to 18 months. So usually a year they're moving. and they're doing what they need to do. Um, but the other piece of that, though, is that I need them to put like reasonable shoes on them so the kids can actually move around. So not the hard bottoms that your mama had swinging from the, you know, from the, you know what I'm talking about, the ones that,
You know, my mother still has the shoe. I'm like,
oh, for the
lady,
love of
how
God.
old am I?
Well, wait a minute now, because I have parents like, well, we need to go get the hard bottoms. I'm like, see, you can't find them hard bottoms, and there's a reason why. There's a reason, and or the baby Jordans that are like hard, and the kids can't bend their feet, and I'm like, they need to feel the floor. So I'm thankful that we're moving more towards food, shoes that are a lot more pliant, so that the kids can actually feel the floor when they're trying to walk. But I typically tell them just leave them barefoot. Let them navigate and feel the floor. So y'all gonna tell me different because I saw Kodai's eye. But that's what I would
But
tell them because that's how
I'm
I was
trying to fix
trained.
my eye, but
Fix
I'm
your
going to
eye,
throw.
but that's how I was trained. That is how I was trained.
That's
Because
and
at
that's
that
perfectly
age,
fine. That's the beauty of having peds and podiatry on. So, Stephen, Dr. Bowie. So you heard her say that, and I want you both, Dr. Kane, to comment on
mhm,
that. So, okay, now we're going to go to peds. We're going to focus on peds for a little bit, and we're going to adults. So, little Stephen comes in. Little Jared comes in, and mom wants to put them in all these types of shoes, or dad. What and they're concerned about a flat foot. Dr. Bowie, first tell me, what does a pediatric exam look like on a child when you bring them into the podiatrist? Dr. Kane, and x-rays, what that kind of looks like in layman's terms. And then Dr. Kane, tell me some of the treatments that you give to your pediatric patients. Dr. Bowie?
Yeah, my first approach, and I really like your comment, Dr. Grundy. Really, our children's feet are craving for attention, really activation. And our feet are designed to walk barefoot, to feel the ground that we're walking on. The issue, or why we're having so many issues from my research, is that we are putting children in shoes too early, especially shoes that are cramping their feet or causing problem. And it's and or even giving support when that what they need is the activation, feeling the ground and building those muscles, the foundation for our feet to get strong. If, in my opinion, if we start giving your feet a lot of support, think of a brace. If you start giving your feet support as a young child, your feet will get lazy. They won't get activated. They won't train in a way to strengthen itself, and it become weakened. So my first approach to the parent, if the child coming in and they complain of painful feet, and the parent look and say, "Wow, look at that! Their feet are very flat compared to mine." And this is where we're talking about the milestone as well. Up to a certain age, their feet are supposed to be flat. They look flat, and it's okay. So unless they have problem with pain, and most of them do, is because of these different type of shoes that are putting different strain on their foot or weaken their foot. So my approach to them is have you allow your feet to develop, to grow, to get stronger, and allowing these kids. Of course, there's certain scenarios where you don't want to expose your kids' feet to a risky environment if you're walking on a road or something like that. But I really encourage parents to delay the time that they put shoes on their feet, on their children's feet.
Now,
Allow them to get stronger.
I'm of West Indian heritage, Trinidadian, right? So, and then being in warmer climates, growing up in Miami, I could go barefoot. I was in the backyard, running, cartwheeling, which I can still do, by the way, and just doing all kind of fun things. Jared, don't laugh. That's not funny. I still can. Don't let this fool you. So I used to do dance and all those types of things, and those are also influencers on the foot, the type of shoes you're wearing, the type of pressure on the foot. Dr. Kane, little Jared comes in, and mom is complaining. Now we're talking about some of the exams and what have you. What are the kind of treatments that, because people are like, kids, what are they going through? For people who don't know, what kind of treatments do we offer children, from conservative to non-conservative? Because you're a surgeon as well.
So, well, the thing about it is, the first thing you have to debunk whatever they read on Google or whatever they've been told in their family about flat feet. Oh, girl, uh, But yeah, my grandmama had flat feet. So yeah. This is what we did. And so you spend a lot of time working against that tide of information. Once you debunk all that stuff, then we can get X-rays and make sure we don't have any underlying pathology that's contributing to the flat foot deformity.
Absolutely.
And once we do that and we can address all that, then the first thing we want to talk about how symptomatic they are, depending on the age and activity level. Then we can talk about maybe getting them into some pair of orthotics. Now, not all flat feet need orthotics.
Wait, Dr. King, for those who don't know, what's an orthotic?
An orthotic is an insert that addresses and helps with the pathomechanics and biomechanics of the foot. So for a flat foot, all right, you will tend to see an orthotic help build up the arch, all right, and then kind of correct the heel to allow them to do their activities and take tension off the ligaments and the tendons in the foot and the muscles in the foot that are help trying to stabilize the arch.
Makes sense.
So that's my first go-to. All right. But with that being said, every flat foot doesn't need an orthotic. There's a guy on this panel who had 2 flat feet growing up and never had any orthotics. I can speak on this.
I like that.
We got to see the. I don't know if you want to show it on the show. I'll let you guys know what we see. So Dr. Kane, now you have a patient. Okay, you've tried all the conservative, lovely things. Doesn't work. Kid is. I'll go, Dr. Bowie. I'm going to jump back to you for a minute. What are the things now that you see in children that are going on to surgery? Because you're right, not every kid needs an orthotic and not every child needs surgery. What do you see in kids that makes you go, besides the fact that these inserts have not worked, what makes you say to a parent, your child may need surgery for this flat foot?
So
and when do you x-ray? When do you x-ray?
And when you would do, yes. Well, you know what, let me back that up. Hold on.
Back up a second.
Yep, let me back up to the x-ray. Dr. Bowie, go back. In terms, that's what I'm saying. In terms of what do you see on x-rays? Why do we take x-rays? And then what decision makes you say surgery? And then both you and Dr. Kane talk about some of the surgeries. Go, Dr. Bowie.
Rephrase your question about what.
My question is, when do you decide that a child needs surgery? What are you looking at on x-ray? And I know you have a different approach now, but talk a little bit about when you think surgery is needed. And Dr. Kane, if you'd like to talk about some of those surgeries as well, go for it.
Yes. So in my past life or in the previous way I practiced, I did a lot of flat foot reconstruction surgery, even in children as well. As Dr. Kane has mentioned, that when we order an x-ray and we see the deformity, and these deformity, the biggest thing I look for is misalignment. And then there are conditions where the bone does not form properly that causes coalitions and causes different
What's
deformity.
That's a big word.
Yeah, so coalition is how the bones fuse together instead of forming separately. That's not the normal way it forms, but sometimes it can cause a flat foot because of that deformity that they were born with or they're growing up with. And certainly certain type of flat foot, particularly rigid type of flat foot, they're not easily corrected with conservative means. So those are the things that we evaluate and determine if they need surgery, if the severity of the conditions and the level of deformity that's seen on the x-ray, and obviously the symptoms as well. If it's mild symptom versus severe symptom, that differentiate the type of surgery that the patient's getting and the severity of the misalignment as well. So those are the things I look. Certainly, holistic approach has limitations as well. So we can only help up to a certain point. But if the deformity is rigid, it's almost impossible to fix a rigid flat foot.
Meaning that foot is not moving.
Where not moving because of a bony block or other issues that's associated with the flat foot deformity. So I'd love to hear Dr. Kane's take on it.
Dr. Kane, so you from either sometimes you have a flexible foot and you're like, this foot looks like doing the monster mash. It's over like this, or you like that one, right? And then you have, as Dr. Bui's talked about, you have a patient that has a rigid foot, meaning that the foot does not move and the foot is stuck in a certain position. You've tried the conservative care. The patient either has pain or not being able to fit into shoes well. What kinds of surgeries, what's the surgical approach? Because parents always like surgery sometimes, or sometimes they're gung-ho about the surgery because they're like, I want it fixed and I want it resolved, right, Dr. Grundy? They want a resolution. Talk about that.
Yeah, so kind of to kind of piggyback on Dr. Bull's point, if there's the underlying pathology, if there's a coalition that's present, which means the bones fail to separate from birth and they form either a bony union or a cartilaginous or fibrocartilaginous or cartilage, soft tissue kind of union, then that needs to be addressed. Now, there have been times where an orthotic has been sufficient. However, surgery would involve removal of that coalition. All right. Now, there have been studies that say that you need to correct the flat foot as well, along with removing the coalition. The thing you have to be careful about is growth plate closures. A lot of patients
What's a
have
growth plate? What's that?
Growth plate is the bones. It's the bones that they grow with, they're born with, and then the growth plates grow into each other in terms of full development of the kid or the child or the adolescent. So if the growth plates are open and they have a painful, rigid, flat foot that has anything has worked, then surgery is an option. However, you're very limited if the growth plates are open, as opposed to waiting for them to close, managing it, waiting for it to close, then addressing everything that needs to be addressed. So that's kind of the tricky, dicey area in operating with peds patients with flat feet. So that's why I try my best to exhaust all non-operative treatments, orthotics, bracing. If you got to come in every year, get those orthotics, and so be it. But we want to do that.
Therapy, I'm big on that too. I'm like, sometimes I'm like, come on, we're going to get this foot moving, grooving. Let's strengthen the tendons. I'm like you and Dr. Boo, I see you doing that. I'm like, we're going to exhaust everything before we cut into that foot.
Exactly.
So how are you convincing these very vain teenagers to wear orthotics? I just want to know, because I've seen orthotics. They're not sexy. So how are you convincing them to wear these? I'm just asking from your perspective.
I'll take this question first, and then I'll pivot it to you two to answer, because I'm a diva. I like to be cute in my shoes. So, orthotics come in various types of styles. You have dress orthotics for young ladies who are wearing more of a dress shoe, or gentlemen that are wearing a dress shoe. If sports orthotics can be done depending on the type of activity. If they have a type for soccer, there's a type for people who may play basketball. So keep those in mind. And then sometimes a more complicated orthotic or an AFO that might be a little less sexy and higher, depending on the pathology. I tell parents, especially when they start getting cute. My niece is 9, and you can't tell her about nothing. She likes her stuff at 9. And so I tell parents, she's my niece, she's my baby. But I tell parents to bring the insert with them and try them on in a variety of shoes that work. Because you don't want a child who's miserable, because kids will take it out at school on purpose and try and put teenagers do it. I remember it's a sneak lipstick. Sorry, mom, if you're listening, at 14, and be like, mom and dad are listening. Oh well, let it go. So that's what I tell parents. And I would say a lot of times that does work within reason. Dr. Kane is making fun of me. What do you tell your pediatric bange, teenagers or preteens?
If it's a girl, I talk to the mother, because the dad is probably playing shotgun. So I say, hey, mom, help me help you. All right. Usually by the time they see me, they bring these plastic bag of orthotics. This is what we've used. Put them on the table. Let's go through all of them. Let's find the one that works the best. And then after we find the one that works the best, then, okay, do we need to make modifications to this, as opposed to, constantly buying them, especially if they bought a lot of them, constantly buying them. But if it's a daughter, I go straight to the mom. Mom, help me out. If it's a son, I go straight to the dad. And we work together. And I said, listen, we have to work together to get this to work. So my biggest thing is really incorporating and informing the patients parents. That way we're all as a team trying to get them to get better.
Dr. Bowie, and then we're going to pivot to another question.
Yeah, I really I agree with you both regarding communication. So important to help them. Well, first we need to understand where they come from as well, and if we show them that we're listening, that helps them to buy in, and then also communicate in the way that they understand. So for me, I want to give them options.
Mhm.
Mm.
So you have choices. There's option A, you have to exercise your feet, certain type of exercise, and work on losing weight. This is one of the biggest issue that I see in flat feet in children. Obesity is one of the driving force in terms of so many more patients in the recent years that I've seen coming into the office that have flat feet or painful flat feet secondary to obesity. It's the main driving force. So they have a choice. Like, listen, you can use the orthotic to help to realign the foot so that your body don't look like a leaning tower pizza in Italy that you're fumbling. You're going to be falling if you're not in good
We're
alignment.
comedians tonight. Everybody, podiatrists. We're not boring. That's our second act.
That's right. So the orthotic will help keep you in alignment. So that's the simplest thing. But more importantly, you got to work on your own health, which is exercise, eat right, and work on yourself. There are modalities that help with the pain associated with the flat foot as well. And if we can help to work together with physical therapy, they can in mild cases, they can work their way out of their orthotic. And I've seen it, and I've seen the good results with that as well.
I do have a
Dr.
question for the
Oh, go
panel.
ahead. I'm so sorry.
How are you having that conversation about obesity with flat feet? Because I mean, we see it. They're saying, and in the bubble in our head is saying, "Man, come on, man!" That's what the bubble's saying, but we can't say that. So, how are we having that conversation in regards to telling them that?
I want to give that to Dr. Grundy exactly. So Dr. Grundy, sometimes I've had overweight children come into my office, but definitely you being the front line for peds, what are the conversations that you're having with these parents about their weight?
So there's two parts to that, right? Because you said a conversation with the parents.
And then the
Sometimes the
child.
parents are the problem, right?
Mhm.
Because if the
Mm.
parent comes in as 300, 400 pounds, and they're commenting on the fact that the child is 200 pounds,
What we doing?
child didn't go grocery shopping, start there. So
Mhm.
that's the first thing, and that's the comment that I usually make. Yeah, I'm very straightforward.
Mhm.
Um, but then for the child, typically they are not as engaged or concerned about it until they're in their teens, right? And those are the kids, particularly the boys, who may want to play a sport, but their feet are hurting because they know they now want to lose weight. Because Dr. Bowie told me to lose weight because that's going to make them healthier, right? So you have to get all these pieces of the puzzle in one piece. The only thing you can say is at some point it's not going to be comfortable. We're going to do our best. Get your orthotics, get your exercise, drink your water, do all the things you need to do so you can be better. But it's not going to happen unless we do one thing first. Put one foot in front of the other, literally, and that makes a big difference with them.
Mm.
But I think the obesity is tackling. It's so many issues to tackle because it plays out in so many ways. Definitely post COVID. I don't know if you all can appreciate it, but for sure the kids are much heavier.
Yep.
And that
Absolutely.
is in and of itself a bigger issue because the kids were home for someone. We did see a bit of a drop when they went back into school, but it's okay to be sedentary now. They did it for so long, so at this point, it's like they figured out the pluses to it. So they're okay with sitting still for way
And the
longer than
reason
we were ever allowed to sit still.
But the reason I asked that question because a lot of times, like Dr. B said, that is a contributing factor, and I can stick whatever magic under their feet, but if they don't address the underlying issues, regard whether it's weight, whether it's activity level, whether it's the other things that are contributing, flat feet just don't arbitrarily. Yes, there's a hereditary component, which means some people are born with it, but at the same time, the obesity factor is real. It is
And
very, very real.
it plays out in everything, literally every facet of a child's life it plays out in every medical issue. It's almost like smoking with adults, obesity with children. It's a thing, right? And even self-esteem. So you're thinking about the kid who was
Mhm.
flat feet, who's in pain, who wants to go do something and be more athletic, but he can't do it because he's in pain, because he's obese, because he's eating things, because he's depressed, because he's home. I mean, it's a big, big, big part, right? But the biggest thing is drink more water. Don't No soda, no juice. Start there, and we'll move forward.
Mm.
I hear you. Well, I'd like to pivot to the adults because we started that. So Dr. Grundy's like, good luck, goodbye, deuces on the kids. So now we have, especially we have our weekend warriors. Everybody's always, and when the new year comes, everybody and their mother is going to be in that gym because we're going to get gym weight on, And we have people who come in with, oh, my aching feet. They've been in Uggs. They've been in all types of the high, again, cute boots with the high heels because you had to match it with your purse. They've been in there, old school Stacey Adams or cool leather shoes, whatever. And
But I'm the old guy. You talking about
Right?
Stacey Adams, Dr.
They're
Booyah.
back in. They're back in, though.
Do
They're
you know
back
what
in.
Stacey Adams are, man?
the old school leathers that your father
That
probably
have
wore.
no give, none.
That's right, no give. I always
I
want to
have
give
to look
shout
that
outs.
up.
I see some folks laughing, but we have a shout out from Charlottesville, Virginia. We see you, Rosalind, and we see Nancy Marie from New Jersey. Thank you for tuning in. So, okay, I'm gonna start backward. Dr. Kane, patient comes in. Mrs. Smith comes in and is like, "Ooh, you know what? I play ball. I basketball with my boys on the weekend. He's 42. He's like, that's my exercise. And now he's complaining of arch pain. And what do you say to them? What is a workup that starts with that for an adult?
So for an adult, we want to get into the x-rays and the clinical examination to, again, address the underlying deformity. Uh, Not every flat foot, has an underlying deformity of where there's something biomechanical going on. Some of it's just hereditary. Like I said, but when it gets to an adult, x-rays in the clinical exam are really important because a lot of times they're not going to come in and say, hey, I have flat feet. Hey, man, the bottom of my feet is hurting. I tried to play basketball, and man, it hurts with the first step in the morning, the first step after rest. And and see them step out, and they just, and that's how they sound when they hit the floor too. Man. But,
Wait, give us that sound effect again, one more time. So if you hear that note, you mean you need to see Dr. Kane.
But at the same time, again, starting with non-operative treatments, because a lot of times this can be addressed non-operatively, and getting them back to where they're able to do their daily activities and the things that they like to do as pain-free as possible. Mm-hmm. So that's always my first goal.
Dr. Bui, your first goal when you first see your patients?
Yeah, I really like your responses there, Dr. Kane, because really, as I was practicing as a surgeon, I practiced pretty much the same way. Now I look at things on a more holistic approach. Of course, we evaluate what's going on, and the funny thing, you mentioned earlier about what they learn on the internet now, ChatGPT, AI, they got AI diagnosis of your disease now.
And they will tell you what their diagnosis is, and you're like, "Do you need me then?" Hey.
And they will tell you what you are supposed to be doing in terms of treated. So this is what I got. This is what I want you to do. Hook me up. I got a parking meter, or I got to hurry and get past the free garage. So hook me up, doc. And don't do it, and you'll get a nasty patient satisfaction score. But that's the next.
That's a very good point. I like the patient, the type of patient that take no ownership of their problem. And I said, just leave your foot there. We'll work on it overnight. And then in the morning, you come back and you get a new foot, and it's brand new. It's the newest and the latest model. Everything will be fixed, right? But kidding aside, there's multiple issues that's coming in, and one of the most commonly mistake that patient come in or misinformation, they come in, they say, I have plantar fasciitis. Well, pain in the arch of the foot. What's going on? It must be the flat foot that's causing the problem. And so for us, as Dr. Kane mentioned, the clinical examination is very important, the x-rays, and the other things that I find more and more, and as Dr. Grundy mentioned about the inactivities, more and more patient coming in with tight gastrosoleus complex. Basically, what it means is the muscle
So
behind
I
your,
gave you the eye, right?
yeah,
Like
that's
what?
right. The tightness in the muscle in the back of your leg, your calves. And that is one of the major contributor to plantar fasciitis, to flat foot deformities. And that's one of the things that on the clinical exam, I really focus on that and try to help patient understand how it's a major driver to the problem, how it could really help them if they work on stretching, rehabilitation, and allow your body. And this is another thing that learning more about holistic treatment, I'm starting to learning how our mind is affecting the ligaments and tendons as well. When we are under stress, we're tense. What happened to our body? It tenses up. Well, it tenses up your Achilles tendon, your muscle behind your calf. It exacerbate your flat foot, exacerbate your plantar fasciitis. So right off the bat, we differentiate: is it a plantar fasciitis, or most of the time the medical term is posterior tibial tendon insufficiency, or adult number one cause of adult acquired flat foot. So
So
those are
that's
the
why
things
your
that,
arch hurts because your tendon is not working right.
right. It causes misalignment, causes a lot of other issues, which the driver could be not where your foot is, but in your leg, in your calf. So those are the things that we help the patient understand, help them be part of the treatment journey. Let them have their ownership of it, because otherwise, those are the kind of patient that won't get better if they throw everything at you and say, "Hey, you fix it." And they're not the one that's getting better because they're not really involved in the treatment of their own treatment. Because I think this is very important. The best doctor for you is from within, is what you can do. We are just facilitator, helping you to get better. That's how I feel.
So let's talk about one of the things that we see runners, and you're a runner, Dr. Bowie. So I'm going to, like I said, I'm not running unless it's from something. I'm terrified of bugs. I'll kill a bug. If it's a mouse, I'm running. If it's a bear, you'll get me to run from them.
That's why you got
For
to be
people,
prepared for that, though.
so for those who like to run, which I admire, I have a great friend. I don't know if she's on, Regina Fleming, who's won numerous marathons. She's completed just it's amazing, just like you. So our runners, what kind of advice they come sometimes jacked up. I've worked the marathon, New York City Marathon, and they're like, ooh, when you see their foot, like, oh. And a lot of times after the race, later, they're like, oh, my arch is killing me, or this. Dr. Kane, I'll throw it to you first, and I'll go back to Dr. Bowie since he's a runner. What do you say to your runners when they come in with arch pain, or they say, I mean, my foot's flattening out sometimes, I think, since X, Y, and Z time?
Well, the thing about it is, when I see the runners, first of all, I congratulate them for being runners and being able to stay consistency with that exercise and that activity. But the biggest thing is especially after a marathon, half marathon, or building up to a marathon, we try to figure out from the clinical exam and the radiology exam, address the condition, but also making sure they still are able to maintain the run. The worst thing you could tell a runner is stop running.
I know that for a fact.
They will hate you.
You get to look at you like,
They will hate you, and then go out and run. However, what I tend to do is I was like, you have to listen to your body. So you have to pull back, ease up a little bit. Let's do these kind of treatment modalities in terms. And listen, rice still works. Rest, ice, compression, elevation. Those things still work for active runners. So I try to employ those. Not so much the elevation, but making sure they rest and apply ice and compression needed to help get the inflammation that is secondary to the flat feet under control and allow them to maintain their running kind of schedule and running abilities.
Sounds great. I want to give a shout out. We have people watching from New York, and dear friend Sora Regina Fleming. Yes, I'm sorry. She's completed marathons. I want to clarify that. Thank you from New York. Thank you from Lynchburg, Virginia. Thank you from Michigan. We appreciate you guys tuning in. Dr. Bowie, since you run, which I marvel at runners. I'm like, why in the world? But that's a story for another day, okay? Because I need to keep working out. Dr. Grundy, right? I'll walk with you. Let's Dr. Grundy, you have to walk, girl.
I
But
walk fast.
run. I don't know. It got to be something chasing you. So, Dr. Bowie, since you elect to run, and you get it because you want to keep running. So, what do you? I'm marveled by especially the type of practice that you have. What do you tell your runners if they're coming in with flat feet and arch pain? What does that look like for you?
Well, first, I have to admit that I have a problem. Okay. And similar to a lot of runners, we all have problems. The problem is that we're having is we are adrenaline junkies. We like the runner's high or the feeling that you can run forever. So anybody that tell you you have to stop, it feel like life is over.
I'm trying to
So
find out where this adrenaline comes from because when I ran, I felt pain and there was no adrenaline. It was like, no, thank you, ma'am. But again, I admire wherever it's coming from. God bless you. Keep going.
yeah. So you're right. When you first start out, I remember my journey. I could not even run 1 mile before I started running marathons and things like that. I was so out of breath that you're right. It was so painful until I start a training program. And not until about 2 months later, 2.5 months later, that's when I start feeling that or experiencing a little bit of that runner's high that they're talking about. And it's not a high like, taking drug high, but it's the feeling of almost like invincibility. Feel like I can run all day. Obviously, you can't. There's limitations, but it's wonderful to have that feeling. And it not only that, it keeps you healthy. So for patients that are runners, the real problem we have is I call it too many two syndrome. Too fast, too soon, and too often. So they tend to because they like that adrenaline, so they keep running. They're running, they're pushing themselves really hard, and they instead of the training program, they push themselves to go more than 10% of the running that they did the previous week. That's usually my threshold for them. Is like don't overtrain yourself. And a lot of runners, the main injuries in runners are overuse syndrome. So yeah, they wrecked their feet. They came in, they expect you to miraculously wave a wand over their feet and send them back running again. But obviously, we have to take care of them. And the biggest thing that I can talk to them and help them understand is, yes, you can do certain activity. The key word is cross training. So if there are certain deformities or injury or issues that they have, they can't run, well, they can bike, they can walk, they can do other exercises that give them the rush as well, and does not allow their body to decompensate. And so that's what they want to hear. Obviously, if you tell them that you cannot do any activities, that to them is like the worst. So those are the things that we advise them to do. In the meantime, that buy them time to give their body a rest to recover and to address the main issues that we're dealing with.
I want to ask Dr. Bowie a question. Then I'm going to go into Dr. Kane about surgery in a second. So, Dr. Bowie, I have someone who asked, how do you treat tired feet, especially when you wake up in the morning and they feel tired? And she's an active runner, marathon runner. What would you say to her? And we want to give a shout out. I see West Palm Beach, Florida. Thank you for tuning in.
So the first caveat is certainly go see your doctor, your podiatrist, to make sure there isn't anything else that causes the tired feet that you're having. If it's just sore, aching, maybe they're not giving their body enough time to recover. So when it's a red flag, when you're waking up in the morning and your feet are sore already. So that's a red flag. And it's this if this is going on for more than 2 weeks, you need to see your doctor right away to address the issue or figure out if nothing else. If it's overtraining, you know what to do. You slow it down and you give your body enough chance to rest. The last part of this, and a lot of patients don't think about, is that nutrition, electrolyte and nutrition. If they're
Mhm.
not eating enough, and recovery, if they're not sleeping enough, and they're not giving their body time to recover, they will wake up sore feet. And it's okay for once or twice, but if they start their day like that all the time, over time your body will wear. And this is where a lot of people say running is bad, because they don't allow their body to grow, to get stronger, and to recover itself. So yes, figure out what's the main cause first. And if just overtrained, then you have options. But otherwise, let your doctor take care of you.
So I'm going to pivot to Dr. Kane. So Dr. Kane, we talked about for peds, which we also do in adult patients, inserts, physical or orthotics, physical therapy, some of the conditioning we talked about for our runners. Now you have a patient, they've been running their foot, they had this much of art, now it's nothing. It's painful. You've done an x-ray, which is our first modality to see if there's any fractures. You're like, this doesn't look great. You've sent them for an MRI. MRI was showing you some damage to the tendons. What type of surgeries are there available for patients with flat feet, adults, that you do for them? Because some people are like, tell us about surgery. We know that exists.
Yeah.
Talk a little bit about that.
Sure. So it depends on their current activity schedule. If it's a high demand person that want to kind of quickly get back, I have to have a longer conversation that, this is going to be a 3-month recovery. They're not going to be bedridden for 3 months, but,
And
it's
you
a
tell my friends who run that, good luck.
So there are different types of surgery to address, and the goal of every surgery is to, especially with adult flat feet, to take pressure off the tendons and the ligaments by creating an arch. How do we go about creating an arch? We make different cuts in the bone at different planes, and this is all geometry, and we're
I
recreating.
hated geometry, so boo.
Yeah. Oh, man. So we're creating an arch in their foot to help the ligaments and help the tendons not be so stressed out when they're walking. So that is what I'm trying to accomplish. Now there are different ways to accomplish that. Everybody's is, if there's some underlying arthritis, those bony cut type procedures, which are called medical terminology for an osteop, it may not be the best thing. They may need to go to what we call a fusion, where we put the bones together, put a screw in place, and get bones to grow in together, and what we call arthrodesis or fusion. That may be better for them, especially if they're older with underlying arthritis or a long diseased tendon. But those, for me, those are the type of procedures that I do in regards to addressing the flat feet. And yeah.
What does recovery look like for those patients? Dr. Bowie, Dr. Kane, give me 30 seconds, Dr. Bowie. Tell me what it looks like. Recovery for your patients non-surgically, and then Dr. Kane, recovery for your patients surgically. Dr. Bowie?
Yeah, for transient flat foot issues with misalignment, if we are able to address the issues, whether with rehabilitation, exercise, stretching, and things like that, obviously the patient that had elect the non-surgical option, or they have that as an option, their recovery is a lot quicker. Um, but more severe cases, what I'm talking about when with my patient, usually give it about a month, and of course cross train during this time, and that's typically how long it takes for your ligament and tendon to kind of settle down and allow your muscle to develop and to take over the issue that you're having. But for surgical, it would typically a little bit longer, and I'll let Dr. Kane elaborate on that.
Dr. Kane?
So from a surgical standpoint, typically it takes about 3 months to get back to full activity and full shoe gear. Depending on the procedure, I may keep them non-weight bearing or partial weight bearing for 6 weeks, followed by partial weight bearing in a boot for 4 weeks. And I always tell them our goal is to get them back to all activity by 10 to 12 weeks. But of course, that's the goal. Things can happen to interrupt that process. However, that is our goal to get them back walking and active and doing the things that they like to do by 10 to 12 weeks.
I too will comment on that. If it's tendon surgery only, which is rare, I will tell them that they're looking at anywhere from at least 8 weeks to feel good into 3 months. And follow with physical therapy using orthotics. I say orthotics is like braces. After you've had beautiful braces, you get a retainer. Same thing with that orthotic. That's your friend, your boyfriend, your girlfriend, wear it. Um, with fusions, yes, I tell them that, or putting bones together when we're using screws or plates or staples or all kind of fun, yummy things that we use for podiatry, I'll tell them 3 months. And then it's a matter of same thing, physical therapy and their inserts. That is your retainer that helps hold the foot where it's supposed to be. A lot
Mhm.
of times with women, well, girl, when I get back into those heels, I said, even with from as much as bunion surgery, when we're fusing bones like the Lapidus procedure, the 3D bunionectomies, which are the hot things that we talked about in the previous show, I say usually when you're able to go on your tippy toes without pain, roll up like a dancer, roll down and walk, then you're usually able to get into a shoe. Unless you can do that, and also swelling may be an option, then that heel is not your friend yet, girl. You might have to go shopping for other things. And so I like the commentary that all of you gave. So as we're getting closer to time, which was amazing, I thank you because I think that these topics are great topics for the everyday person and for our other medical colleagues who may not see things like this to know about, where they can say, oh, Dr. Bowie told me AB, you're go see so and so. And Dr. Kane said, okay, where is he at? So what I like to do from each one of you, starting with Dr. Grundy, give me your 30-second spiel. Where can we find you, social media, and where you practice, please? Dr. Grundy?
I am a pediatrician, general pediatrician in Maplewood, New Jersey. Part of Primary Care Partners, Trinity. Oh Lord, now you're asking me social sites. I don't remember. On Facebook though, if you look and you put in Trinity Pediatrics, you'll find me.
Awesome. Dr. Kane, where can we find you?
I am at University of Pittsburgh Medical Center in Pittsburgh, Pennsylvania. My social media, which may bore you, but hey, it's my social media. It's DRJ for Feet on TikTok, Instagram, and Twitter. I think my Facebook account's still active. Don't go on there a whole lot, but nevertheless, it's on there. So DRJ for Feet, and my email is Cain, CAIN 1074 at gmail.com. Anytime, any questions from anywhere around the world, I'll be more than happy to assist you in any way I possibly can.
Dr. Bowie, losing my voice. Dr. Bowie, where can we find you? Especially, and I'm going to tell you the tag with everybody here. As I said earlier, Dr. Grundy is my friend, my femmes noir sister for Black female in medicine, all fields of medicine, and we're friends. Dr. Bowie and I went to the best school, haha, Dr. Kane, the New York College of Podiatric Medicine. And Dr. Kane, like I said, when you come recommended from Dr. Lowell Wild Jr., then you become family. So, Dr. Bowie, where can we find you?
Thank you, Dr. D, for giving me the opportunity today.
You're
Where can
welcome.
you find me is uh, in the Appalachian Trail of Pennsylvania. That's where you find me running on this trail. But professionally, I practice in Waynesboro, Pennsylvania, and I like to focus my practice on sport medicine and help people recover from their injury, from their running. And that's my focus, primary focus. I travel around the world in Europe and Asia to teach physical therapists and doctors on recovery. And you can find me on Facebook and Instagram with the tag Dr. Active, at Dr. Active on Facebook and Instagram. And obviously, if you look me up in Waynesboro, Pennsylvania, you find me there as well. So thank you.
And it's your favorite girl, Talks with Dr. D. Talk to Dr. D is a three-pillared approach to health, wellness, medicine, and advocacy. This is our stepping forward with Dr. D is the podiatry part, but you can also find me for our breast cancer awareness and also for Sisters on the Vineyard, where we talk advocacy, health, wellness, Wusaha. With last time, as many people know, our previous speakers were Sunny Hostin from ABC's The View and Malik Yoba. But my time, which would be New York Undercover and
Look
obviously our
undercover.
established shows, Empire. You can
JC.
find me, right? Yeah, I'm showing my age, right? You can find me at Talks with Dr. D on social media, on Facebook, Instagram, LinkedIn, and my website, talkswithdrd.com. Thank you so much. Tune in monthly as we talk all things of the lower extremity podiatry. Next month, it's always the first Wednesday of each month at 7 o'clock. We're going to have our Christmas special or holiday special because Kwanzaa, we're going to talk about Hanukkah. I love it all. So we hope you guys will tune in. I thank you to Dr. Grundy, Dr. Bowie, Dr. Kane. Thank you so much.
Yeah.
And we thank you, the people who support us, as we love you. This is recorded on blackdoctor.org, pardon me, or my YouTube channel, which I'm putting in right now, which is Talks for Dr. D, where you can share with your friends and keep the information going and like us because we need those likes. And with that, we bid you adieu. Thank you, everybody.